Welcome to the deep dive. Let's start with a moment of, well, real pressure. You're in a clinic, a patient needs an urgent referral for some highly specialized physio. And just as you're about to write it, you have this flash of memory.
Yeah.
Your partner has a big financial stake in the only local place that offers that exact service.
Right.
The patient is right there looking at you. What do you do in that split second? How do you protect the patient and, your own professional standing?
A classic and very stressful scenario.
Exactly. So today we are doing a deep dive into conflicts of interest, or COI. We're working from a really structured set of notes, a sort of tactical guide on how to act with high integrity, all aligned with the General Medical Council.
The GMC, yeah.
Our mission here is to find the shortcut, to pull out that crystal clear, high-scoring response you need when your ethics and your finances suddenly collide.
And that immediate clarity is everything. A conflict of interest, well, at its simplest, it's any situation where your personal interests, maybe financial, maybe a relationship.
Or even something institutional.
Exactly. Where any of that could influence your professional judgment.
Okay, so could influence. That's the key part.
That's the absolute key, because here's the professional and ethical point we have to anchor on. It's not just about whether it actually influences you.
Right.
It's whether it appears to influence you. In the eyes of a reasonable patient or a colleague, the standard response, the only safe pathway, is always the same.
Which is?
You declare it. You avoid influencing the decision. You offer alternatives. And you record everything.
I am really struck by that standard. Why is the perception of bias treated just as seriously as actual bias? I mean, surely a doctor's own commitment to being objective has to count for something.
You'd think so, but that's where the GMC's Good Medical Practice logic really comes in. Trust is the absolute foundation of the doctor-patient relationship.
Okay.
So being transparent, stepping back from a recommendation, that isn't about proving you're a good person. It's a non-negotiable safeguard for patient trust.
So if someone even suspects your motives might be financial?
Even if you know they aren't, that trust is damaged. The sources are absolutely clear on this. Maintaining patient trust is central. Anything that puts that trust at risk has to be managed and managed transparently. That's the logic that gets you high scores.
Okay, so let's unpack those core standards. The goal, as you say, is to act above suspicion. What are the specific anchors from the GMC that we need to be thinking about?
Well, the first one is the foundation for everything. Make the care of your patient your first concern. No financial or other interest should ever affect that care. That's the starting point.
The absolute non-negotiable.
The non-negotiable. And second is what I'd call radical transparency. The guidance says you must tell the patient if you or someone close to you, like a partner, has an interest in something you're recommending. And you have to explain why you're recommending it based on clinical need, not profit.
And what else?
You have to share all the reasonable alternatives, and the guidance is explicit. That includes the NHS options. And make sure the patient knows they can get a second opinion.
That feels specifically designed to stop someone pushing an option that benefits them, requiring them to mention the NHS route.
It is, precisely. And it goes beyond just one-to-one conversations. As professionals, we also have to follow NHS England guidance on managing COI at an organizational level.
So things like registers for gifts.
Exactly. Registers for gifts, hospitality, anything that could potentially compromise you. It's about integrity on every level, from the individual up to the whole system.
Okay, let's talk about the big warning signs, the red flags, the situations that demand immediate, really structured intervention.
Yeah, the source material details 4 patterns that really demand that clear framework we'll get to in a moment.
What's the first one?
The first and the most common is a direct or indirect financial interest. That's the scenario you started with, your partner owning shares. Or maybe you do some part-time work for a private company and you're thinking of prescribing their product to an NHS patient.
Right, that's a clear one. What's next?
Second is gifts and hospitality. And we're not talking about a branded pen. We mean something substantial, especially if it feels like it's linked to your prescribing habits or referral numbers.
Like a fancy educational dinner hosted by a drug company.
Precisely. That creates a perception of influence. It has to be declared, or even better, just avoided, depending on the rules of your organization.
Okay, number 3.
Dual practice. This is where a recommendation you make in one job, say in your NHS role, could directly benefit your other job, your private practice.
Oh, I see.
The patient has to have a clear, unbiased choice between the NHS and private pathways.
And the final one?
This one's a bit more complex. Organizational pressure. Let's say your hospital trust is under pressure to generate revenue, And maybe those internal targets could push you towards recommending certain in-house private services.
Even if it's not the absolute best option for that specific patient.
Exactly. That becomes an organizational conflict, and as the clinician, you still have to manage it transparently, always in the patient's best interest.
The pressure points are very clear. So now we need the tactical response. You're in that room. What is the foolproof step-by-step method? Let's talk about that clear framework.
The clear framework is your checklist for when you're under pressure. It's designed to make sure you hit every single professional and legal mark.
Okay, let's break it down. C.
C is for confess or declare. You have to be honest and prompt. Flag the conflict, whether it's real or just perceived, to everyone who needs to know.
The patient, your colleagues.
The patient, colleagues, your organization. And critically, this has to be in writing, in the notes or on the register.
Got it.
L is for limit influence.
Yeah.
This is often the hardest part. Where it's feasible, you have to withdraw from the decision-making process. You physically step back and get an alternative, impartial clinician to take over that decision.
Okay, but that step back mandate, that sounds incredibly hard in a busy, understaffed clinic. What if you're the only expert there?
And that is a major trap. The sources are really firm on this. The professional standard is to withdraw. Now, if, and this is a big if, you are the only person available.
Yes.
You still declare the conflict, you document absolutely everything, and you arrange for a second opinion or a full review by someone else as soon as it is physically possible. The declaration and transparency are non-negotiable, even if stepping back is delayed.
Okay, that makes sense. E.
E is for explain transparently and offer alternatives. You've got to make sure the patient gets genuinely unbiased information, cover all the suitable options, especially the standard NHS pathway, so they have a real choice, not one you've steered them towards.
Right. And A?
A is for alternatives offered. It's reinforcing that point. Make sure the patient knows they have other choices and the right to a second unbiased opinion. It puts the power back in their hands.
And finally,
R is for record. You document the entire process, the conflict, the advice you gave, the alternatives you offered, and this is crucial. Who made the final decision? Which, ideally, is the patient, with advice from that other clinician. That documentation gives your protective audit trail.
so what I'm hearing is that your personal intent doesn't really matter. It's the appearance that protects trust, and the documentation proves you followed the process. What does this actually sound like in practice? Can we have some model phrases?
Yes, you want language that's direct and establishes integrity straight away. So instead of trying to be subtle, you say something like, I need to declare a potential conflict here for transparency.
Straight out.
Straight out. Then, I will immediately step back from this decision and arrange for an alternative clinician, Dr. Z, to discuss all your options with you.
That's very clear. Another example.
Or, if it's more about policy, you could say, for transparency, I should let you know I have a connection to that particular service. An equivalent NHS option is available, and I can arrange that for you right now. Or you can speak to my colleague about the private route. You offer both, right there.
Let's switch over to the pitfalls. Where do people consistently go wrong with this? The sources point out some pretty powerful cognitive traps.
The first big failure, both professionally and in any kind of evaluation, is trying to rationalize it away. The trap is thinking, I know I can stay objective, so I don't really need to declare this.
Right, the I can handle this mentality.
Exactly. And the reason that fails is simple. Ignoring the perception of bias destroys trust. It doesn't matter how objective you feel inside if public trust is at risk. You have to manage the conflict, not deny it exists.
That is a tough lesson, that the professional standard just overrides your own self-assessment.
It is. The second common failure is accepting gifts or hospitality that are too valuable, especially if they feel tied to your prescribing. A sandwich lunch in the clinic might be fine, but a big sponsored trip. That's a breach of NHS policy and screams commercial influence.
And the third one?
The third is actively recommending a service that benefits you, especially if you push it before you even mention the NHS options.
Yeah.
That's a serious ethical failure. Fairness always outweighs personal benefit.
And just to clear up an edge case, what about a perceived conflict? Say the patient thinks there's a conflict, but you're absolutely certain there isn't one. Do you still have to go through the whole process?
100% yes. The source material is definitive on this. The appearance of bias is enough. You have to manage a perceived conflict just as rigorously as a real one because the damage to trust is identical.
So this deep dive has really shown that managing conflicts of interest isn't about, avoiding professional relationships altogether. It's about having a rigorous, transparent system in place. It seems to come down to spotting it early, taking yourself out of the final decision, and documenting every single step.
That's a perfect synthesis. And to give you one last memory hook, one of the sources uses the mnemonic F-AITHER. Flag the conflict, avoid influence, inform transparently, get third-party support, and honestly record F-AITH. It's a good reminder that trust is what you're protecting.
F-AITH. I like that.
And here's a final sort of provocative thought for you to take away. We've talked a lot about how patient interest has to outweigh personal benefit.
Oh.
What happens when that conflict is institutional?
Go on.
What if your employer's revenue targets are pushing clinical decisions in a way that isn't in the patient's absolute best interest? The principles we've covered suggest you have to be prepared to declare that organizational conflict too.
Wow.
So what happens when your loyalty to your patient is in direct conflict with your loyalty to your employer?
Yeah.
Something for you to mull over.